So where did you sort of see it fit into the calcified lesion algorithm? Like, how do you look at something and say, all right, how do you know if you need like a calcium modification tool? And then once you make that decision, how do you kind of go through like, well, maybe I'll use this or this? You talked a little bit about that. It used to be length and now that's changed a bit. Walk us through how you sort of evaluate, I need something, and then what's the thing I need?
Yeah. I mean, I think, there are myriad calcium algorithms out there, and I think they all have value. They all are kind of predicated on the same few principles. For us, the cornerstone of all of this is intravascular imaging. I think we all know now, hopefully all know now, that angiography is a very poor discriminator for coronary calcium. We teach our fellows that if you can see calcium on the angiogram for fluoroscopically, it is then by definition severe coronary calcium. If you see it at all on fluoro, then it's very likely to be severe. And so we image more or less 100% of PCIs. Certainly 100% of calcified lesions are assessed with imaging. If the imaging catheter goes first, then you can use that to inform the rest of your, treatment in terms of, the degree of calcification, the arc, the length, the vessel size, etc. But we will often do some pre-treatment ahead of time rather than, trying to get the imaging catheter in. For me, if it looks uncrossable and very, very tight or subtotally occluded, those are still cases that we're treating with atherectomy. For me, my workhorse atherectomy device is rotational atherectomy. We do some orbital too, but predominantly rotational atherectomy. And then like you kind of alluded to, my use of large burrs has more or less evaporated since coronary IVL has become, routinely available. So it would typically be in an uncrossable lesion, atherectomy upfront to facilitate delivery of other devices. After that is augmented with IVL. And, we'll use imaging to decide on the size of the IVL catheter, and again, size it 1:1, and then go ahead and treat with that, and then confirm your modification before stenting. Again, we all want to teach people to do image-guided PCI, and, it's hard to then ask people to do an extra imaging run, but I think if you are treating severe coronary calcium, it is 3 runs that you need. You need the baseline, you need one peri-modification to confirm it, seeing calcium fractures, and then you need that one at the end. In a non-calcified straightforward lesion, I think 2 runs is completely adequate pre and post, but I think if you're treating these complex lesions and calcified lesions, we do try to teach people to do that extra peri-modification run to confirm adequate modification, and then the final imaging run, post-stenting. So yeah, atherectomy for me these days is more or less for uncrossable lesions. I would say, or lesions that appear to be uncrossable. We don't always prove that it's uncrossable, but if you see a very, very tight lesion, subtotally occluded, severe calcium, etc., then we'll treat those with atherectomy. We had a big randomized trial of atherectomy recently for Eclipse with orbital atherectomy, and I think what's important for people to remember about that, the headline finding is that there wasn't a significant difference between atherectomy and conventional balloon angioplasty. Those were not uncrossable lesions. So none of us are saying that, atherectomy is not useful anymore, or throw it out, or has no role. But I do think that its role is probably becoming restricted to these uncrossable lesions just to facilitate delivery of other devices later.
Yeah, I was going to ask, are there cases outside of these balloon uncrossable imaging, catheter uncrossable lesions where you find yourself using atherectomy, or do you really think it's sort of now finding itself confined to that bucket?
But yeah, since we got our hands on Aero, it has really, really, I think, shrunk more or less to that. Again, although I say lesion length is not a major factor now with 120 pulses, if you have an LAD, which is 90 millimeters of severe calcium that you're going to have to treat the entire thing, then yes, I think atherectomy up front can help. I think nothing helps device delivery as much as atherectomy, and it will often make the case more efficient and quicker and smoother, particularly when your lab is facile with it. But I think that, yeah, as I said, since we got Aero, I think more, almost for me, it's becoming restricted to these truly uncrossable lesions.
I want to back up just a hair to something you were talking about on using sort of imaging to guide PCI. I think, it's a drum people have been beating for quite a while. There's clear data that it improves hard endpoints. And so really seems like, gosh, why are people not doing this? For you, when you are utilizing these in these calcified cases, what are the characteristics? So when you do your run, what are you looking at to say, I need to use calcium modification here? Because again, and we're not talking about ROTA necessarily because you've gotten across. So what are the things where you need to say, all right, I'm going to use a specialty balloons, IVL, something?
So, we look at, as I said before, there are multiple of these algorithms, and people can, pick one and use one and follow one, but they all basically have the same fundamental principles in them. So one is the arc of calcium. So, how close to 360 is it? A lot of the algorithms give you kind of 1 point for 360, irrespective of if it's just one focal spot or not. But even, being close to 360, above 270, some greater arc of calcium is going to push me towards calcium modification, particularly if that greater arc of calcium is over a longer length. So, very focal calcium does, I think, tend to respond relatively well to balloon angioplasty, but longer areas of calcium, which are, greater lengths. Obviously, the tighter it is, if the MLA is small, oftentimes we see calcified arteries that are calcified, but the lumen is enormous. There's no stenosis there. So obviously the lower the MLA. And then nodular calcium, I feel like even in the, short period of time from when I was training to now, I never heard about calcified nodules when I was in training ever. And now every meeting has like a seminar dedicated to calcified nodules, and we talk about it for hours. And, we could talk about nodules because I feel like none of the techniques that we have are perfect for treating nodules. If they were, then we wouldn't have all of this kind of conversation and thought dedicated to it. But again, calcified nodules will prompt me to do a little bit, to think more about doing calcium modification. So those are really the major factors that I would look at.